Hello, everyone. So I am so excited to be able to talk to you guys about blood transfusions today. This is probably one of my favorite things that I was able to do early on in my career. Was be able to talk about blood transfusions and lecture about this at conferences. So I've kind of graduated into other things since then, but blood transfusions and stuff are one of my favorite things, and it's one of those things that we handle very delicately. Blood is very, very sensitive, and we have to be very careful with our blood products. And you know, uh, we have to also remember that when we are giving blood products, to be sterile as possible because we can create an environment where an animal can get very sick if we don't handle it sterilely. So it's important that when we're working in a practice giving blood transfusions to make sure that we advocate for those patients and say, hey, make sure you're wearing gloves, making sure that when we're putting our administration sets together, when we give it, that we do it in the most sterile possible way. So, crushing products is very simple to do. And so I've seen people, crushing plasma because you're thawing it out and they're like, oh my gosh, it's slushy right now. So they're, slushing it around so much and crushing up all of those. I'm like, oh my gosh, you're ruining that product. So you have to treat it very delicately. So, but blood transfusions are really cool. Can do a lot for a patient, make them feel so much better. But we have to remember that during this time, blood is just a band-aid until we can get that patient feeling better and that their body is essentially going to produce more red blood cells or produce, any type of coagulation factors that it needs or anything like that. So I do like to tell owners, like, this is just a band-aid until we can get the body functioning appropriately again. So keep that in mind when we do a blood transfusion. It's not a cure, but just buying time. So I call it a band-aid. So when we go through our what a blood transfusion is. So when do we want to transfuse the patient? So it doesn't just mean, a number. There is no magic number for a blood transfusion. And a lot of people go, oh my gosh, well, we have this cat that comes in and a blood transfusion is necessary because a cat's pack cell volume is, 14%. And that's not necessarily true. Like um, a, a cat could come in that's in renal failure and is totally acting normal and his packed red blood cell volume is 14%. Um, and and it's been like that for some time. So we don't necessarily need to give a blood transfusion per se because we're wasting blood. Essentially, what's going to happen is that those red blood cells are just going to last for a small amount of time, and then that body is still not going to produce any red blood cells. So we have to understand the body process and why that renal failure cat isn't producing red blood cells at that present moment. So, we might have a better treatment for that animal, So, does that cat really need red blood cells? Does it seem like it's in distress at that moment? We only need to transfuse if that animal is clinical for needing that blood transfusion, right? So, there's certain things. So, is the patient clinical? Um, so, uh, it's not about the number, right? It's about, okay, what does clinical look like? Is the patient not able to breathe appropriately? That's number one, right? The patient not doing well per se. Is the patient sluggish? And do you feel like that number is going to decrease, right? Is the patient actively bleeding? That type of thing. And is it worth the risk? Right? Is it worth the risk of giving more blood? Versus giving the patient the treatment that they need per se. So, are there other options that we can do as well that might be better for that patient. So just like that renal failure cat, is it worth the risk of giving the blood for that patient versus treating the patient and see how they do first with giving, in that case, what we would do is give erythropoietin, or EPO as they call it, right? And so that will help that cat be able to produce red blood cells, right? Because the erythropoietin is kind of at a standstill from the kidney disease. So um, we can do that. Is it worth the risk? Because we don't know if there's going to be a transfusion reaction. We are able to blood type, but there's so many other factors that even if we blood type and cross match, they still can have a blood transfusion reaction from all of that. There's still reactions that can happen as well. And they can still lyse all of that regardless. And just remember again that a transfusion is not a cure. And also, how long does this transfusion last, right? So the max that it's going to last is about 35, 36 days, the max. But we also know that this patient is severely sick, right? Severely sick with something or another. And so we don't even know that, whatever it's sick with could lyse these cells even faster than um, if it's a patient that's not sick. So maybe this patient isn't sick and it's just, lost blood from a hit by car or something like that. So we may have that one last a little bit longer. But if it's something like an IMHA, it could lyse the cells in a day, so it's not a cure, but it's a band-aid. So we have to keep that in mind as well. So we might be having a crazy battle on top of that. So we have to keep all of this stuff in mind. So how are we going to treat it long term? So what are the types of blood products that we have, right? And so what does that mean? So we have fresh whole blood, right? So fresh whole blood would be that we have a patient that needs fresh whole blood with everything that we need in it that is totally coming straight from the body, right? Red blood cells, white blood cells, platelets, everything that we have coming straight from a patient. So we call in an animal to come and donate blood, and they donate the blood and they give it to a patient right away within 48 hours, right? Ideally, 4 hours would be great, but usually about 8 hours is our max, and they have to give it right away. So that would be fresh whole blood. Stored whole blood would be if we anything after that 8 hours, we store it, and then we keep it up to 35 days. Okay. After 35 days, it is expired and we have to throw it away. It's no good anymore. All right. Um, our red blood cells are totally exhausted, and that's when they die off. So there's no oxygen left on those hemoglobin, and they die off and they're gross. And you can tell, it's kind of interesting because when you look at the whole blood, you can tell kind of which bags are a little bit fresher than the other ones because they start kind of changing color a little bit. The fresh whole blood is really red versus kind of the stored whole blood kind of starts turning more of like a darker red color. So now packed red blood cells. Packed red blood cells are they take this whole blood and they take a huge centrifuge, and they spin that whole blood down and they separate out the red blood cells and the plasma, and they leave about 10 to 20, I think it's about 10% of the plasma left in there. Um, and and then that they have the packed red blood cells just left in there. And then essentially packed red blood cells has about 70% a PCV, uh, and maybe slightly higher PCV than that. That's in packed red blood cells that they give to patients. So you just have a higher amount PCV than if you were giving, whole blood to an animal. So that way, rather than having to give whole blood, sometimes animals just need the red blood cells, right? They don't necessarily need plasma to give the animals. They just need red blood cells. So like those IMHAs that, you know, they have severe anemia because their PCV at that point is like, you know, 15, 18%, we can give packed red blood cells that will hopefully jump up their PCV with less amount of, a blood transfusion. So we'll give them packed red blood cells. Fresh frozen plasma is a plasma is the basically the leftovers of those packed red blood cells, right? So fresh frozen plasma is plasma that is less than 2 years old. It's frozen. So we keep that in the freezer for 2 years, and you can thaw it out in a warm water bath. Um, Typically, we are trying to do it so that we don't have to thaw it in any type of warm water bath anymore, any of these, if possible. And so I kind of will talk to you guys a little bit later about how you can do the warm water baths. They even now have, though, nice containers that you can buy for blood products that are commercial, that are really cool, that I've seen, that protect them solely from like water as well. So that's kind of cool. Frozen plasma is plasma that is older than the 2 years, and you guys can keep those up to 5 years of time. After that, we have to throw them away. So, what happens is that after the 2 years, the clotting factors get exhausted out, right? So in plasma is good for protein building. There's protein obviously within the plasma, and then there's also the clotting factors, right? The unfortunate thing is, yes, we have our platelets within our whole blood, correct? Platelets get really exhausted right away. They're very sensitive. And the only time the platelets are really good within our blood is our fresh whole blood. All right. They are not good in any type of plasma product. They are totally at any point after that, they're going to be killed off. So if you need platelets, they're not going to be good for any of the things that we talked about so far. They're not going to be good for any of the rest of those things. Okay. So, but if you need clotting factors, the fresh frozen plasma is really good. So, any of your rodenticide animals, you can use fresh frozen plasma as well, and then you'll be able to have some clotting factors. Now, for frozen plasma, we can use that stuff for any type of, you know, protein building type of things. We can also use it for um, antibodies as well. So, say you have a parvo puppy who needs antibodies to kind of build up the immune system, right? If you have frozen plasma, you'd be able to use that as well to kind of help build up any type of antibodies because essentially their immune system is really bad. So you can use frozen plasma. You can also use fresh frozen plasma too. You can use any type of blood products as well, except for packed red blood cells, unless they are, if they're anemic or whatever. But that would help even a parvo puppy or anything immune compromised. Now, the next one is platelet rich plasma. So, platelet rich plasma is a treatment that is really expensive. It was probably at the time when I first started in practice about $800 just for 1 unit of platelet rich plasma. And we have to remember that a normal platelet count is about 200,000 to 500,000 platelets, right? So if you have a patient who has usually zero platelets, right? This is when we consider doing platelet rich plasma, zero. Okay. and we need to have 200 to 500,000 platelets. Platelet-rich plasma will increase your platelets. Just 1 unit will increase your platelets by 10,000 platelets per unit. Okay, so think about that. 10,000 platelets per unit, but your normal platelet count is 200 to 500,000. So it only increases at 10,000, but you need 200 to 500,000 platelets. Okay. So it's only increasing it by 10,000, but so you'll technically, to get to normal range, you'll need about 20 units of it. So it only gives you a little bit at a time. So it's just, again, just kind of a boost. And so it's not really as helpful as we really would like. Platelet plasma is also incredibly sensitive because platelets are incredibly sensitive. So it is uh, it is frozen when you get it. You have to thaw it out, not in a warm water bath. It has to thaw out at room temperature. So it does take a long time to thaw out, and you have to be incredibly gentle with it. Does have DMSO in it to keep the platelets alive. And so DMSO smells really bad. So your patient starts to smell really bad when they're getting it. So I feel really bad for them. It makes your whole ICU smell terribly too. But uh, hopefully it just kind of bumps up your animal's platelets. They do have freeze-dried platelets now. Typically, it's used for animals that have acutely started bleeding. So that is kind of what's being used for it. Another type of blood product we use is cryocipitate. So we use cryocipitate for animals who have like von Willebrand's disease. And typically we use that um, ahead of time prior to surgery, just in case they are going to have any type of bleeding, you know, um, bleeding issue during surgery, just to make sure that they don't. So that is one thing that we have used. Um, Oxyglobin is a product that we used a long time ago. It then went off the market and is now back on the market in the UK. It's not on the market here as of yet, but it is just essentially a um, synthetic bovine hemoglobin. And so what we have used it for is essentially if you don't have any type of blood products, so if you don't have a whole blood or stored whole blood, packed red blood cells, anything like that, or you don't have like the specific blood type, like especially for cats, you can actually give oxyglobin to those animals. And it's just, again, a band aid until you can get them the blood product they need. Um, and it just carries oxygen to the tissues of their blood. So it was really good for the time being. You do risk, obviously, them lysing cells and having like an icteric type of urine, but it is a good band-aid for the time being, of course. So um, we have human albumin that we have used in practice. This was again before we had canine albumin. So if you do have access to canine albumin, it's much um, easier to give, and they have less reactions to canine albumin. Um, but if you have an animal who has a low albumin, it's much better to give albumin to a patient for protein building than plasma. You would have to give a lot more units of plasma to your patient than having to give albumin. So it's much more recommended to give canine albumin than human albumin. Essentially, human albumin, if you're thinking of puzzle pieces with albumin, human albumin is the puzzle piece of albumin just doesn't quite fit into the puzzle. And so that's why we have a little bit more reactions with human albumin than canine albumin. But it does the job until, the body can function more appropriately. So now that we have canine albumin, it's nice that we can use it. Immunoglobulins is kind of easy or kind of fun. So again, we can use this for like our puppies that have parvo, any type of immunocompromised animals. But this one is kind of cool because we've been able to use this in cases of those cats who have really, really high blood pressures, like your renal failure cats, who I always say their blood pressure goes so high that they blow out their retinas. So I don't know if any of you guys have ever seen that, but their blood pressure gets so high that their retinas detach. And so what we end up doing is giving them a treatment of immunoglobulins. And a lot of times their retinas can reattach and they gain vision again. So it's really kind of cool how that works. So this is kind of a products that we use, and to me, I put this together, and I actually put this together at first just kind of for myself and utilizing this in the um, specialty practice that I was working at. And I had a bunch of interns that I was working with, and they loved this. And so they asked me to share this with them so that they knew what they could be using and stuff. So I figured I would share this with you guys. This is not something that you have to know, obviously, for the VTNE or anything like that, but it's nice to just kind of have so that you guys know, okay, this is what I could be utilizing for the future, or just kind of having an understanding of, all right, this is what kind of works with what. So it's kind of a nice little tool to be able to use because there's so many products now that you can use, and there's way more products now as well. So and some things we can auto transfuse too. So like rodenticide toxicity, there's nothing wrong with the blood that is being seeped into whatever space it goes in. So we are able to do auto transfusions, which is really nice as well. All right, so canine typing is really awesome. So you guys should have learned this already. So DEA stands for dog erythrocyte antigen, right? So they made it really simple. So D is just dog, erythrocyte, and then the antigens that lay on the erythrocytes. So if you think of the erythrocyte, 1.1 is just one of the antigens that is on the erythrocyte. There are 13 known antigens that are on that erythrocyte, and 1.1 is just the one that causes the most harm to animals. So that's the only one that we check in practice. But if you are, having animals come in for blood donations and stuff like that, you're going to be sending out to check for all of the different antigens so that you know that hey, they actually do test for like 4 or 7 and stuff too, because you do want to know exactly what is on their erythrocytes. Um, there are no freebies. Personally, I mean, we don't say that in any type of medicine, like I don't want my animal to have any type of reaction ever. There should be no freebies and everything. There's always room for error, right? And so we need to make sure that we just cover our bases, right? So it says there's no significant natural occurring antibodies, but I have seen transfusion reactions and bad transfusion reactions on first time animals that get transfusions. So um, you have to just be careful, and it doesn't take long to type in a cross match in animals' blood. So we have to go on best, or I should say, the highest standard of care, especially with this higher end of care as well. So 60% of DEA 1.1 negative animals, so we call those guys universal because that means that they don't have that antibody, and they can donate to either DEA 1.1 positive or DEA 1.1 negative. So they're universal to everyone, right? They're givers to everybody. So I have at the bottom here a nice little picture. Sometimes that helps people to be able to see like who they can give to. And then I have a chart at the top too that kind of says, okay, who they're able to give to or not. So it's really easy. So if they're positive, they can only donate to the positive. If they're negative, they can donate to both. All right. So we always recommend typing and cross matching unless the blood is needed right away. Okay. So if they're needed right away, we just try to pick a DEA 1.1 negative and give that DEA 1.1 negative blood right away. You can, I've done it a cross match type a thing. If you're totally stat and have to look at it right away, just taking a drop of blood from um, your donor blood and your recipient blood and putting in a slide and doing it that way. If it's that much of a stat where you can't do it, and looking at it that way, and making sure that that looks okay. But I have not had it to where it's been that needed that fast, unless it's like a hit by car or something to that effect where you need it right away. Otherwise, I've been able to um, do a blood typing across match as well. So this is what our blood typing stuff looks like for the most part. So we have our old cards that have the rapid vet H. Some people still have those. There was a lot of room for error just based on how people were reading them. So they do have the quick tests available, which looks kind of like a pregnancy test. So they have your control line that's there, and then they have the test line. So it has a C on there and then a T on there. So the C should have a line, and then the test one, if it comes up with a line, that means that it's positive. If there's no line there, it means it's negative. So that one made it to be really easy. And then the rapid vet H for the 1.1, the positive control shows that there's agglutination there. The negative control shows that there's no agglutination there. And then the patient test, if there's agglutination there, whatever one that the patient test looks like is the one that it matches to. So if there's agglutination in there, that means that it's positive, and if there's no agglutination in there, that means that it's negative. So that patient there looks like the positive control, so that patient is 1.1 positive. So they're always not that obvious, so that's why it was kind of hard for people to know exactly if it's positive or negative. So that was canine. Feline typing is a little bit different, obviously. So feline goes on the AB system. So it's not as easy. There's no DEA, dog erythrocyte antigen, of course. Cats have to be different. They're on the AB system. So they have AB, AB, and then there's MIC. And MIC is a little bit different, as it's like an addition to A, B, and AB. So I don't really consider that per se to be its own blood type, because it's not. It's just an added blood type on there. And it's pretty rare. So there are no universal blood types for cats, of course, because there are no cats that are normal. Let's just say that. So 90% of your domestic short hairs, domestic long hairs are type A. Okay. So we can at least kind of know going in with domestic short hairs and domestic long hairs that, hey, okay, we're going in, and hopefully that at least will tell us that domestic short hairs and domestic long hairs are type A. However, there are so many cats out there that are mixed breed cats. We can think that, yes, this is a domestic short hair, domestic long hair, except for the fact that a lot of them are shelter animals, and even though they may look like a domestic short hair, domestic long hair, they could have some sort of purebred in them, right? And so you never know if it's going to be a type B cat as well. So there's a lot of purebred cats as well. So the purebred cats could be a type B. So it is really important that we type all of our feline cats. They do have natural occurring antibodies in their plasma, so there are no freebies, and they can have really, really bad reactions that could be life threatening too. So this was like a very, very drilled into us when I was in school, like you will kill a cat, you know. They don't necessarily mean like they will kill a cat within 5 seconds of giving it. That's how I felt when I was in school going into practice, like, oh my gosh, I'm going to kill a cat immediately. Um, they can have really severe reactions and, stuff like that. So you just have to be really careful. So our type A cats, they can um, donate to type A and type AB. Okay. So a really important thing to know is that type B cats have really, really bad natural occurring antibodies in their plasma. They do not like um, any anything else, right? They will fight anything else. Okay. So we can't like put type B blood in the type A category. Okay. So um, but in the AB aspect of things, we can put that type A in um in the AB. I'm sorry, we can't put type A in the type AB because it's a slightly different, but we wouldn't be able to put type B in the type AB because the type B blood has that natural occurring antibody in it. So the type B blood would be very angry about the AB animal's blood, if that makes sense. So the antibodies from that blood would be very upset. So, but the type AB cat is already accustomed to the AB blood. So it's very interesting. Um, so it's better for the AB cat to receive um, its own AB blood, which is very hard to find. It's a very rare blood, or we do many times just give A blood for that one. Type B cats can only get type B. And again, it's very hard to find type B blood, but when you do find a type B cat to donate, we definitely keep them. So okay, so blood typing, very similar to our dog as well. So you have like your pregnancy looking test there, and that's just kind of how it's set up actually to do that test. So it sits in a little well and it kind of soaks in that blood mixture that you make. So that's what the test strip looks like. And same principle, it'll show you the control line and then the test line. So if it shows up, it'll show up whether it's A or B. And then if it's AB, both lines will show up. This is the rapid vet H. So what happens here is it has an auto agglutination saline screen. So that saline screen just shows if there's any type of auto agglutination. If there's auto agglutination, then we won't be able to do this test because auto agglutination is going to give you a false reading. And then the A and the B here is going to tell you if they're A or B or AB. And so if you see any agglutination in these, then you'll know if they're A or B. So here we don't see any agglutination in the A. So this cat would not be type A. We see agglutination in the B. And so this cat is type B. So we want to see agglutination and that would give us a positive for what type they are. So why do we want to cross match? We have our typing, but why do we want to cross match? We know what type our patient is, so why can't we just like give that type now, right? It should be okay. So transfusion reactions can occur, right? They can be fatal. It can be costly if it's not done the gold standard way. Yeah. So we need to take each transfusion seriously, and there's can be a lot of errors, right? So cross matching is really important because we are taking the blood of the patient and the blood of the recipient, I'm sorry, the blood of the patient and the blood of the donor, and we're essentially doing a blood transfusion in a tube first, just to make sure that we are going to not have any reactions before we give it to our patient, right? And so it's just our way of making sure that our patient's going to be okay before we actually follow through with it. So it's actually a very simple process. It just takes a little bit of time. So what we'll do is we'll get a blood sample from our patient, and then we'll also take a small sample that's provided from our donor. And we're going to separate out the plasma and the red blood cells from the donor and the recipient, right? So it goes through that process. So essentially, we'll have four different tubes. Okay, so we'll have our plasma and our red blood cells separated out from our recipient and then from our donor. And so essentially, what we're going to do then is we need to wash off our red blood cells um, from our donor. Okay, so we're doing a major cross match here. And so we're gonna wash off our red blood cells because we want to make sure that we're getting any type of debris or stickiness and stuff like that off of our red blood cells so that we don't have any type of false reading on our cross match. And so what we'll do is we'll take some saline and put it in just another tube. And then we're going to take just a little bit of our red blood cells from our tube and put it in the saline. And we essentially just invert it a few times and just wash off those red blood cells. And then what we do is we place a little bit of our recipient plasma into three tubes and our washed off donor red blood cells into three tubes. And we incubate those tubes for 15 minutes in three different temperatures. So one's going to be a cold temperature, one's going to be a warm, like body temperature, and one is going to be room temperature. Okay. After that, you just centrifuge it for 10 minutes just on a low speed, and you're going to evaluate it grossly, like this person here, to make sure that you don't see any hemolysis or like that button, we call a button at the bottom, that it isn't, that it didn't form at all. And just make sure that you don't see any type of agglutination on your own, just grossly. As long as that looks good, you're going to mix it up again. So you'll kind of flick it and mix it up again. And you'll take a drop of that and look at it under a microscope and look for any type of agglutination or anything that looks suspicious, hemolysis, stuff like that. So once that looks good, you should be good to go for your transfusion. So the difference here, right? What is the difference of agglutination versus rouleau, right? So we have to know that difference. So microscopically, rouleau looks like this, especially in cats. It can be normal, but rouleau is just the stacking of each other, right? They're not smashed on each other like agglutination. They're all smashed. There's no definition. It just looks like smashed grapes, right? So this would not be normal. And this is what we say is a reaction. We don't want that. Rouleau, obviously, and like cats would be normal, or horses is normal. In dogs, we may see here and there, but it's not overly normal to see this, especially. But I'd be better okay than seeing obviously this. I would definitely note that if you saw this for your doctor, though, as for sure. But definitely notice the difference in those guys. So again, this is not something that you have to memorize or anything. This is just another thing that my doctor's like, oh my God, this is so great. Um, But noticing this as what the dosage is, and the rates for packed red blood cells, whole blood, plasma, platelet plasma, stuff like that. Something that it's just been kind of nice to have, and easy to grab, so that you know. But something really important to note is that your blood transfusions should be completed within 4 hours at a time. And, starting at a low dose, like 1 milligram per kg for the first 15 minutes, and then slowly going up from there, is really important. Or, stuff to that nature. So, like, our packed red blood cells, I think we started at 5 mg per kg per hour, usually. Sometimes we started at a little bit less. Um, and and just kind of going from there. Um, but we always did ours over 4 hours, because bacteria starts to grow after 4 hours. That's the biggest thing. Um, so that's really important. Making sure to, and I think we'll probably talk about it, but making sure as well, no medications are given during the time of blood transfusions, no feeding during a blood transfusion as well, no drinking water, because if they have any type of vomiting or anything to that nature, we want to make sure that it's due to the blood transfusion and not due to the fact that, maybe they ate food during that time or had a medication during that time. So we do have to wait on doing certain things. So handling of blood products. So how do we need to handle them? Make sure that you stay sterile, especially when you're splitting bags, touching blood bags and stuff like that. They're semi-permeable bags. So that means that anything that you touch on that blood bag could potentially get into that bag. So making sure you're always wearing gloves when you're touching the blood bags. It drives me nuts. Follow the storage and expiration dates. Even if it expired the day before, it's expired. So making sure that you follow those expiration dates, wear gloves, and stay sterile. You'll see that a lot in here. I really mean it. Do not crush the bag, okay? So you'll see this blood orange. Like, I'm not kidding. I've seen people crushing those bags, and it's really, really obnoxious. Gently inverting the blood unit, at least every hour, especially like when you are on the floor giving the blood transfusion to the animal. Just walk by and invert the bag, just to kind of mix everything together, especially with, the anticoagulants and stuff in there, just making sure that it is mixed nicely. And then follow the warming instructions. So never warm your products over 98.6 degrees Fahrenheit. So if you are warming your product in a warm water bath, making sure you're checking the warm water bath and that is not greater than 98.6 degrees. Double bagging your product at least, unless you have a nice warming product unit, which are awesome. But it should stay at 98.6 degrees. Stay sterile again. Once your patient is attached, they are attached until they are done, and keep that IV catheter clean at all times. And use the appropriate size catheter. Don't put in a 24 gauge catheter and think that, your blood is gonna squish in there nicely. You don't want to lyso cells before it even gets to your patient. So put in an appropriate size catheter so that your cells actually have a chance to help your patient. Oops, sorry. And splitting bags. So there are many times that we don't have to give the entire bag to a patient. So you might have a small patient and you might want to split the bag so that you can give half of the bag now and maybe half of it later. Because if you have the bag out and you give half of it over, half of the product over 4 hours and you have the whole product out for 4 hours, you have to waste that product then. So if you split the bag, you can then save that other part of the bag for later. So splitting the bag is a perfect option. So make sure you wear gloves, use a sterile blood collection bag, be as sterile as possible. So even utilizing, a drape, anything to that nature. used like 2 to 3 clamps to make sure that it's airtight, so keeping things really tight in there. They do have, like, as you'll see here, like those, hemostat looking things, they're made out of plastic, so utilize those too until you're able to get your actual clips on there. They're just kind of like little rings that you put on there, and then hook them on and clamp them really tight. Store unused blood and your product in a refrigerator for no more than 5 days. So I made sure to verify this with my blood product guru, Kenyagi. And that is what he has said for years now. And so I'm going with that. So it's no more than 5 days. And then when you guys are splitting the bags, so the big way of splitting bags and everything, remember that 1 ml equals 1 gram. So how we do that is by using gravity and splitting those bags by using the gram scale. And so a lot of times we'll do it that way. So you'll see, especially when you're in practice, how blood collection is used by using gram scales and stuff as well. So and this is obviously the centrifuge that's used to kind of split like your packed red blood cells and your plasma. To do that, these are a lot of the things that you'll get. Um, but yeah, this is the process of splitting bags. So transfusion setup. So how will we set up everything? So determine what the product that you need and how much is needed. Pull the unit that's going to expire first, and then usually photocopy that unit so that you can put it in your patient's chart. That's really important as well. Making sure that you have the actual front end, like every part of that unit to log it is actually in your patient's chart. I am a huge advocate of making sure that everything is documented and put in your patient's chart. So log it in a logbook, put, anything. Include your patient's first and last name, if it's in a department, date it, initial, whatever doctor is being used. We already talked about like making sure that it's, if you're warming it, that is no higher than 98.6. Some people, they don't even warm it anymore because by the time it gets to the animal anyway, it's usually warm. So they just kind of start it. Um, and then if you need a smaller unit, of course, needing to split the bag, so making sure you do that. Always wear gloves, especially when you spike the unit. That's what it's called, to spike it. So when you start the unit and have it um, like put spike the line and get the line used like done or down to the patient, right? Um, and then um this just goes over like using the metal clamps to clamp everything off, place the remaining blood in your fridge, and making sure that you have your patient's name on it and how much you removed, that kind of thing. Um, so priming for your blood transfusion. Look, he's so handsome. I think this is after, oops, I moved, says, oops, now it's going to make me go through all these. Dr. Morris from ER, because he has red hair, maybe. I don't know. So prime your blood transfusion administration set, avoiding as much air bubbles as possible. And then making sure that you do like a TPR before you start your blood transfusion. So get a baseline of your patient, connect your patient and start your blood transfusion at 1 ml per kg per hour. Um, you can use any pump that is calibrated for blood, right? Some people have used syringe pumps if they needed to, especially for smaller patients. If you use a syringe pump, though, you have to be careful and make sure that you have an uh, appropriate filter for that patient for the product that you're using. And so uh you you have to double check on those guys, okay? Or you can use a drip rate. So a lot of people have discontinued using any type of IV fluid pump because they don't want to crush any of those cells. And so I think probably, oh goodness, this has to be probably 5 years ago, many technicians, um, like Ken Yagi, I'm gonna say, him as well, who again is probably one of the number one, blood transfusion people, we're pretty on it with, not using, uh, IV fluid pumps and doing drip rates. So, drip rates are important to know because that might be something that people are not doing for blood transfusions. So just keep that in mind. Syringe pumps, again, might be something to keep in mind, but with whole blood or packed red blood cells, I'm not sure that they have anything that's appropriate yet for filters on that for syringe pumps. So. And then patient monitoring. Typically, we monitor right away when you first start up, and then every 5 minutes for the first 15 minutes, and then as long as everything looks good, nothing much has changed, we can then go to from that 15 minutes we'll increase the rate so till half of the final rate that they'll be at. So if their final rate is going to be at 60, we can increase it to 30. And then we'll check them again in 15 minutes. So at that 30-minute mark. As long as everything is good, we'll increase them to that 60 mils an hour. And then we'll check them in 30 minutes again. And then from there, we'll check them at 90 minutes and check them we'll check them at 90 minutes and then 120 and then 180 and go from there. So we kind of increase it over time. Um, Once the transfusion's complete, there's still going to be some blood in the line and stuff like that. So we typically flush the line with saline, so 0.9% saline. It does say only saline on here, but that was actually before plasma light came about and we learned more about plasma light. But we can actually use plasma light as well because plasma light has a great pH and is very similar to plasma itself. So we can actually flush the line with plasma light as well, but they are the only two um, crystalloids that we can use to flush the line for any type of blood transfusion. So no LRS, no Normar or anything else. Okay, so just 0.9% saline and plasma light. Once the transfusion is complete, we then disconnect our patient, evaluate our patient, make sure that things are good, then give any type of medications, and essentially go outside for a walk and everything because they probably have to go to the bathroom and stuff too. So what are we monitoring for, right? So we're monitoring, their CPR, if they're going to be febrile, right, or heart rate increases, or panting, or anything like that, right? Um, we're also monitoring for any type of vomiting, facial swelling, urticaria, which is hives. So like this dog here, obviously has some hives going on. Poor thing. It's so cute, but I feel bad for him. Pruritus, so itching. Um, Anything that just seems weird to you, right? You're just like, there's something wrong. More serious reactions could be like collapsing if the animal seizes. Obviously, loss of consciousness or death is very serious. So these are things that we're looking for as well. Um, and so other complications, these can be obviously later on reactions too. So hemolytic reactions and non-hemolytic reactions. So hemolytic reactions being, that um, the red blood cells didn't last as long, right? The next day, they PCV was down a ton. Like they lysed all the red blood cells. Non-hemolytic reactions, again, are the febrile, vomiting, that type of thing. acute lung injury, being that, this panting and, um, uh, you know, uh, um, fluid in the lungs, stuff like that. Fluid overload itself, we've ran our blood transfusion too fast, at a too high of rate, which I've actually seen. Like I said, I worked in specialty, and so I had a doctor who wanted to give our blood transfusion over an hour. And so we slammed it really fast. And our patient obviously did not respond well with it. So we then had to kind of backtrack and do a lot of other medications to help that patient. So it was a lot. Other infectious things, right? So if we are giving, um, blood from another patient that hasn't been treated for something else or hasn't been vetted with stuff. We can be giving bacterial infection, we can give viral infection somehow, or parasitic infection. And then hypocalcemia or hypomagnesemia is things that can happen for animals who have been given multiple transfusions. And this could be due to the amount of um, anticoagulants that are in our blood transfusion bags, and it's pulling out the calcium and magnesium in our animals' body. So it's something to consider as well. So remember that these guys count on our gold standard of care, right? Um, they are our patients. They count on us to be their advocates. And even though we're busy every single day, we may have a ton of patients that we're caring for. And they might not be able to speak for us. We may think that they don't know, or their parents don't know, or it might just be easier to do it this way. um, we can't compromise their care because we're busy, right? We know the difference of the good way um, versus the easy way, right? And these little things that we do can make the greatest difference to their health, and their lives really do depend on it. And so, just keep that in mind when you are taking care of them, and just never compromise this powerful treatment that they have as well. So, that is all I have for you guys. So I hope this helped bring a little bit of light to what you guys know about blood transfusions. Take care.